So for those who are just joining us, if you would do us a favor and type in your name, position, credentials, email, and facility affiliation to chat, we track this so that we can continue to get funding for this program. And Heidi, I'm going to stop my share and let you take over.
Okay.
Ready to go?
I think I am.
We'll give a couple more minutes there, Heidi, then I'll introduce you. We'll give another minute or so for some people to sign on.
And Heidi, we're seeing your presenter view again.
Oh, gotta do the other view. Let's see.
Thank you.
All right, perfect.
I'm glad you knew how to do that because I wouldn't have understood those instructions. I would
She already talked me through it once.
Oh.
I'm a repeat offender.
Okay. So it's 11:02 and I want to be respectful of everyone's time. So I think we're going to get started here. We're pleased, following the theme that we've been kind of talking about the last couple of weeks, and Dr. Koo presented the last couple of months, and Dr. Koo presented last month, regards to urinalysis and UTIs and urine stewardship and all the trials and tribulations that everyone encounters in that arena. We have a very good presenter this month. I asked and she accepted Dr. Heidi Simons from Helena and St. Pete's. You still call it St. Pete's? Is that?
St. Peter's Health now.
Let's see, St. Peter's Health. Okay. So Heidi's a clinical pharmacist there and with a specialty in infectious disease. And so she has a keen interest in a lot of these in antimicrobial stewardship, and particularly in, as she likes to say, the bane of her existence here is urine stewardship. So she's going to present a couple of projects here. And so Dr. Simons, take it away.
Okay, everybody, I'll first say, please go easy on me. I have a cold, so I sound ridiculous. So if anybody can't hear, please just let me know and I'll try to repeat myself. Or if I start hacking, just pretend you don't notice. So I'm really happy to present on urine stewardship. I will say, I think it's maybe one of the biggest hurdles for antimicrobial stewardship that we've had to go through here at St. Peter's Health. And it's something we're still working on. Every day we're working on it. Every day I'm talking to providers about it. So in the course of my day, I look at every patient on antibiotics and I come to find out how important it is to review the diagnostics to be sure everybody's on the same page and we're making an accurate diagnosis. And I think through doing that, I learned that, wow, maybe our diagnostics are the problem. It's not often that the antimicrobial prescribing, I mean, that's a problem too, but a lot of times it's really the diagnostic piece. And how can we make a better diagnosis? How can we be more accurate? Not just to prescribe less antibiotics, but to get a better diagnosis for each individual patient. So we've really done a lot of work here. So, I'm looking at patients every day, and I also sit in the emergency department in the mornings kind of to help with overflow patients, kind of post-COVID. So I see a lot of urine in different aspects of care. So we'll dive right in here. Let's see if I can get going. So we all know this, Dr. Koo probably presented on it, that UTIs are the most common bacterial infection requiring medical care. We see a lot of ambulatory care visits, and we'll kind of get to how that's sort of the urine Wild West, in my opinion. You know, in the hospital, that's a different story, but in the outpatient side, it's really difficult to get a handle on that. They're the #1 infection leading to antibiotic prescription. Catheter-associated UTIs are the most common type of healthcare-associated infection. And so with all the concerns for inappropriate antibiotic use and development of worsening resistance, it's kind of prompted the need to look at this concept of urine stewardship, which also relates back to urine diagnostics. So we all know antimicrobial resistance, huge problem. And so it emphasizes, again, looking not just at our antibiotic use, but at our diagnostics for infections. So urine stewardship is what I would say is diagnostic stewardship for UTIs. And that refers to the modification of the process of ordering, performing, and reporting of diagnostic tests to improve the treatment of infections. So here at St. Peter's, we try to perform UAs and urine cultures only when appropriate indications are present. And that would mean symptomatic and laboratory evaluation. We collect the urine samples, store them, and process them in a manner to prevent contamination. And then we evaluate those samples using the best laboratory standards. And I will put an asterisk there and say, of course, there's not a great standard. So that always makes it difficult. So day to day, when I'm talking to providers out there on the floor, I'm talking to them a lot about diagnosis. I'm correlating the presence of symptoms with laboratory findings. You know, I can't tell you how many times a day I get people calling and saying, oh, the UA shows infection. It's like, wait, well, the UA doesn't show infection. You know, the UA might help support the diagnosis of infection, but let's talk about their symptoms. You know, I try to discourage culturing of urine for isolated psychiatric symptoms. Certainly, if that patient has other systemic signs of infection, that's different. But a lot of times it's, you know, little old lady came in, she tripped and fell over her dog. We checked her urine. She tripped and fell over her dog, right? So a mechanical fall versus something else. We're talking a lot about uncomplicated versus complicated, you know, complicated patients. It's maybe not as cut and dry of a list as it used to be. I consider complicated patients to be those with a risk factor for failing therapy. We critically evaluate labs and cultures. We look for a UA here at St. Peter's with 2 or more criteria that would indicate infection. Taking UA as the imperfect diagnostic that it is, we do our best with it. We look for a urine culture that grows 1 pathogen, 80 to 100,000 colony forming units per mil. But if a symptomatic patient has less than that, we'll consider treating. We look at our treatment choice. We look at the spectrum of antibiotic, consideration of how ill they are, previous micro, penetration to the urine, risk for adverse drug reactions, risk of resistance, their adherence, their drug interactions, their allergies, their organ function. I think the biggest thing that I talk to providers about is local susceptibility patterns from our antibiogram and their previous culture history. And then we look at duration, you know, the shortest possible duration. And we've all kind of looked at that. The antibiotic kind of course has had its day, and shorter is just as efficacious as longer in most cases. And so when we're thinking about how to tackle the problem of urine stewardship, I think the first step has to be to define your problem. And so here at St. Pete's, that was define your problems, plural. So when I looked at patients that I was seeing every day throughout my daily evaluations, I was seeing patients treated without symptoms based only on UA. The UA was often on order sets as screening. So preoperatively for orthopedic procedures was a big one. All those patients got a UA pre-op. It's part of the yearly physicals and quarterly evaluations in long-term care, whether or not people have symptoms or not. It can be ordered commonly as part of a non-infectious workup. I see this a lot with CHF exacerbations, where it's ordered to see if patients are spilling protein into their urine, but then it reflexes and then we treat as a UTI when really they didn't come in with those symptoms. You know, symptoms is a very broad term for urine. It can range from confusion to classic dysuria and urinary frequency. Another problem, kind of nailing that part down. There's a kind of a concept that, you know, a lot of providers think pyuria equals infection. So remembering that other things cause pyuria. The UA, when I initially arrived, reflexed off 1 criteria, and it was reflexing too frequently. People would come in, you know, you cast a wide net in the emergency department, for diagnosis, and it would reflex, and the patient came in for a headache. We're checking urine and it's reflexing. And then when you see that positive or abnormal urinalysis and then a positive culture, it's just a very powerful nudge for providers. We would see the UA was not critically analyzed. And this was something I got a lot of fight when I changed the urine reflex criteria here. Providers were like, it's not reflexing, I have to look at it. And I'm like, excellent. I'm so excited. You have to look critically at the UA and decide if you really think that is a urinary tract infection, rather than it just autopilot going. And then antibiotics prescribed inappropriately. We're still seeing some of that. So these are all the problems. So I think at your own institution, you have to define what your problem is and then find something. There's a lot of projects that are maybe smaller, low-lying fruit that are easier to get after. And then there's kind of the big projects where you swing for the fences. And frankly, I've failed several times when I've done those. So here's a snapshot of all the projects we've done here at St. Peter's. So I took this job in 2016. I started developing the AMS program. There had been a little bit done, but from Tom Richardson, the previous AMS person here at St. Pete's, but really we had to start from the ground up. We had to see we did a gap analysis to see what kind of regulatory requirements we needed. And then we kind of went from there. So between 16 and 17, I was just doing a lot of patient evaluation, kind of getting used to the culture here and looking at patients and noticing, wow, we culture and treat way too much urine. And we don't obtain urine samples correctly. People taking them right off the Foley bag, clean catch without being clean, not really considering that each patient is different and we have to get a sample that best fits that patient to get the best diagnosis. So we'll go through a lot of these, but kind of up to and including, right now I'm still looking at the ER order sets. I'm trying to take UAs off when they're not needed in each order set. The lab asked me to write an S-bar to say we're no longer going to work up urine if there's multiple pathogens in there, and they want it to be kind of law. If there's 2 to 3 organisms at greater than 100K and it was taken off an old Foley, they're not going to work it up. So we still are working on things. We're still trying to improve practice. So let's take a deeper look at these. So project number 1. So this was one of my first pharmacy residents here at St. Pete's, kind of something you can simply do if you particularly have one agent that's a problem. So for us, that was fosfomycin. Fosfomycin is a really incredible agent that's kind of localized effect to the bladder, covers a lot of resistant pathogens. But what we would find is people would use it as kind of a catch-all. Oh, this particularly in our behavioral health unit, as part of a medical clearance for a patient who had psychiatric issues and was being brought in. So, we did an MUE. We just pulled patients that had received fosfomycin. We looked at those. There were 55 patients in a year's time. 9 patients, so 16%, had pathogen symptoms and UA culture results that require fosfomycin and its broad activity. And when we dug a little deeper, we found that we were using it more frequently in the BHU because of concern for QT prolongation and inconvenience of one and done dosing in those patients. So, and we then kind of uncovered an additional problem that we'll come back to, where we were treating patients empirically for UTI or getting a UA for medical clearance into our behavioral health unit, which maybe is not always necessary, right? Medical clearance is a much more general term and it doesn't mean urinary clearance. Also, we found that we were using fosfomycin mistakenly for pyelonephritis. So we decided to write some criteria for use. And so Shay Fanning, one of our first residents, excuse me, went ahead and wrote this lovely criteria that helps us be able to, through my Antimicrobial Stewardship restriction program, when an order was popped up for fosfomycin, I could just look at the criteria. I could look at the patient and assess if they had a risk for QT prolongation and then call the provider and suggest an alternative. Pretty easy project, really. The next project is one that I actually did to obtain my SIDP certificate for antimicrobial stewardship, to ensure that there were durations and indications on each order for antibiotics. So, sorry guys, here comes, where's my cough drop? So prior to 2017, if you ordered an antibiotic, it just got a 3-month stop date on it. And so the duration of antibiotic therapy, as always, is up to the provider, but there was no nudge helping them decide how long to go. There was no, okay, I chose it for complicated UTI, that's going to be 7 days as a general rule. So I came up with, okay, I only got 20 indications because we have Meditech as our EMR, so we're a little bit limited. But if the providers use the order sets, so let's say they used our UTI order set, it would automatically populate an indication and duration. If they didn't, it was a hard stop and they had to pick an indication to put on their antibiotics. Now, this might seem small, but it's actually a regulatory requirement by CMS and Joint Commission to have an indication and a duration on your antibiotic set. So it's a pretty easy sell to upper management to be like, oh, well, we have to do this. And incidentally, it'll help for our stewardship. So here's kind of what it looks like when our providers will go in to put in a ZOSIN order. It'll show a clinical indication. You have to click on it and find the right indication. I will say initially I had providers just picking whatever, but people have gotten used to it. It takes time. But this is an example of something where, okay, you can put 5 days on your uncomplicated UTI and it'll just profile in there, and everybody kind of gets that nudge that we need to be thinking about durations of therapy. Other systems might have different EMRs that allow you to do more complicated diagnoses. This seemed to work for us. It's not perfect, but we can kind of get there and at least have thought of duration right at the beginning. So moving on into 2018, the kind of one of the most important pieces of data for urine or literature for urine stewardship came out, and that was the 2019 update by the IDSA for management of asymptomatic bacteriuria. I love this document. It's just great. And it gave me the springboard I needed to go after a bigger urine project. Because in 2017, I knew we were culturing too much urine. And I went to the Antimicrobial Stewardship Committee and I went to P&T and I said, we need to change our urine reflex criteria. And they said, you don't have data? Too bad, we're not going to change. You don't have literature backing? Too bad. Enter 2019 when we had this delightful article. So we all know what asymptomatic bacteriuria is, but what I really liked about this round of guidelines is it helped to tackle some really contentious populations that had previously been left out of the guidelines. So we all know that a positive urine culture encourages antibiotic use, and sometimes it's too powerful of a nudge, so to speak, to get the provider to not do it. So a big push here on don't obtain urine cultures when not clinically indicated. And there was a lot of great stuff in here. This is one diagram I really like and I use all the time in my practice. You know, the prevalence of asymptomatic bacteriuria for different populations. And I really like at the bottom, persons with indwelling catheter use. Short-term catheters, colonization at 3 to 5% per day. And then long-term catheters are nearly 100%, well, they are 100% colonized. You know, I still get people who are surprised that we get multiple organisms off a catheter, and trying to change the practice of you have to change the catheter so we can get a clean catheter, so we can get a good sample because there's so many colonizers. But I really like this. I bring it up a lot in daily practice. So places where we were falling down here at St. Pete's, this is a tough population we see a lot in the ER. So the guidelines would say in older community dwelling persons residing either in the community or long-term care, they recommend against screening for ASB. How about when they come in with a functional or cognitive impairment with evidence of bacteriuria and an acute mental status change? So they said without local GU symptoms or systemic signs of infection, assess for other causes, careful observation. This was a little bit, you know, stronger of a recommendation than the previous guidelines. Same for a fall. Recommend looking for other things if they don't have obvious fever, hemodynamic instability, or GU symptoms. So this was something I thought, wow, we really have a springboard here for some of these tough cases where patients come in primarily with fall or psychiatric symptoms, and we always kind of find urine to be the culprit because it reflexes and grows. Another place we had trouble was, again, patients with an indwelling catheter. You know, this would kind of say, these patients are nearly always bacteriuric, usually polymicrobial, you know, so don't treat asymptomatic patients. And if you do have a symptomatic patient, change the catheter before you get the sample. So a couple of things I really like in that paper. So these were opportunities for improvement. After we looked at these, you find a great paper, you find things in there that, wow, we're not doing that, or, oh, shoot, we are screening every patient prior to orthopedic surgery. Okay, these are little chunks that I can use to build my case. And so based on this document, I went back to the committees and I said, listen, here's all the things we're doing. I want to get some data and I want to try again. So I did. So I looped yet another resident into pulling 100 patients, 50 inpatient, 50 outpatient. I said, I want to see how we're doing. I want to see if some of these practices from the asymptomatic bacteriuria guidelines are in there. And so we looked using our current reflex criteria, which at that time was a reflex, I'll show you on the next slide, for one criteria, and then our proposed. And I will say what's been hardest about some of this is there's no one standard for reflex criteria. You kind of have to do your best, knowing each thing within a UA is somewhat fraught with its own issues. And, the more you look into UA, the more you're like, ooh, it's not really a great positive predictive value, but it's the best we have. So this is kind of what we looked at. We looked for no result, we looked for who got treated, and we tried to not have overlap with another infectious disease. So we looked at, okay, here's our current reflex criteria, one of the following. We had 39 patients with no urinary symptoms. Of those 39, 29 had a UA reflex. We had 10 patients that actually had a culture result, 19 patients who didn't. So when we looked at changing our criteria, we certainly cut down on the number of patients who would have a reflex, which was good. But it kind of highlighted that 39 patients that we were getting a UA on had no symptoms. 11 of those actually had positive cultures. Again, that really powerful nudge. And then 15 of those 39 were treated with antibiotics. So when we looked at the sensitivity and specificity that might come from changing our criteria, we found that we would increase our sensitivity, but keep our specificity and have a yearly cost savings. And if anybody's interested kind of in the background math, I can certainly provide that. So we actually brought data this time. We tried to make it compelling, something that hits people in the wallet's always compelling. For me, it's more that those patients are exposed to antibiotics and exposed to excessive cost, and we probably didn't get the right diagnosis. Okay, so using that, we use that as our rationale for finally doing a big project and changing our urine stewardship. We evaluated our practices. We said we looked at our 100 samples. Patients are being tested and treated despite not having symptoms. This was kind of our background. Another thing we found is that patients were being tested for cure after being treated for UTI, another no-no. Our sample collection was all over the map. We have a great 3-tube sample collection system here at St. Pete's, but we weren't using it to stabilize the sample. We weren't collecting samples correctly. So we recommended to change our urine reflex criteria and try to go from a more global approach of improving urine stewardship. Huge project. But we finally got it done. So in 2019, right as COVID was about to hit, I snuck this in right before COVID. I developed the SPH UTI pathway, which can be used both inpatient and outpatient. Big project, but something I will emphasize that my mentors emphasized, and maybe I just thought I could get by without it. You got to have the data though to back it up. And that's maybe the hardest part about these projects. So we made this pathway that was comprehensive, could be used all over and within our nursing homes. It emphasized a symptomatic evaluation first to verify that you needed a lab evaluation, incorporated use of our 3-part urine collection kit to get the best sample possible, utilized new reflex criteria, helped providers interpret the culture, and then provide evidence-based literature and local antibiogram treatment guidance. So Dr. Anglem, who's our infectious disease provider, head COVID person, she wears a lot of hats around here, but she's really done a great job empowering me and backing me up and saying, you want to do this? Let's do it. She's just absolutely fabulous. So here's what we ended up doing to our urine reflex criteria. We went from current practice, which was one of the following, we changed to 2 of the following, and we removed bacteria just as a component. Although some people like to see bacteriuria, and this is where I'm like, great, look for it. It's just not going to be a reflex criteria. For dipsticks, we do not use those inpatient, but they're used frequently in the clinic. So we tried to put some criteria around those and improve use on the machines so that the providers would actually see them before the visit was complete. We changed our orders. Previously, when a provider went to order a urine culture, it was just cath or non-cath. Well, does cath mean indwelling cath, or does cath mean straight cath? Or, well, you don't know, and they don't have to say. So I changed it to be 3 different reflex orders indicating sample source: straight cath, indwelling cath, and then a clean catch. I was not allowed to put a hard stop to say, have you changed the catheter before you send a sample, but I'm still working on that. And then you can still order a urine culture here at St. Pete's outside of reflex, but it's basically restricted to certain populations, you know, urology patients preoperatively, OB patients, and then peds patients who are not toilet trained. So here's our different orders and urine culture criteria. So I'm just kind of going through that. That's how we propose to change it. And I will say people have gotten used to it. Again, not without complaining initially. Change is hard. So we do have a nursing order that when a patient gets an indwelling catheter specimen order that should cue to look to change the catheter, but it doesn't always happen. I'm still working on it. Collection kits. We have these lovely 3-part collection kits that are free of charge to SPH affiliated clinics and facilities that help stabilize the sample until they can get to the lab. So we really emphasize they're free of charge. Please use them and how to use them appropriately. That's another thing that, like, as a pharmacist, maybe I didn't think of. Are we getting the sample in the right tube instead of just putting it in a cup and letting the colony counts double for every 20 minutes it sits there? And you know, it's only good for an hour as it sits there. I mean, working in the ER, I see a lot of pee just sit on the counter. And it was funny, I just educated a nurse the other day. You could put it in the 3-part collection kit. What does that do, Heidi? Well, it stabilizes the sample. Still working. So here's just a snapshot of kind of the diagnostic pathway for our urine, our urine pathway. You know, it walks providers through it, kind of talks about watchful waiting, you know, normal urinary symptoms, catheter-associated urinary symptoms, and then general symptoms to look for, maybe in a patient who does have new onset confusion. And then the backside kind of walks through treatment options and different places to use these treatment options depending on previous micro or, you know, and looking at durations that make sense with the latest literature. So I'm happy to share that if people are interested. I would rather have more of these out there that make sense that you could modify for your own institution than saying, I need to keep this for myself. And it's a lot of work to make this, but there's no need to reinvent the wheel either. Next project, educating all of the nurses, mandatory education for all the nurses and nursing homes on the new reflex criteria. Everybody was thrilled. So we emphasize a lot with those nurses, diagnostic stewardship, why we want to collect a good sample, looking at our reflex criteria. You know, we talked about how a big push for us is not to limit money or not do more work. But if you have a sick patient, you need to know what the diagnosis is, and you need the best sample so that you can figure out what antibiotics to give to get that patient better. We don't want patients sitting there, you know, stewing and being sick at a long-term care facility. But also there is a cost associated. Patient comes in, provides a sample, contaminated. Patient comes back in, provides a sample, contaminated, when you could have just done a straight cath sample and gotten a better sample initially. We talked about collection kits and how those help, the preservatives within those help keep the urine stable, so that you don't have such a rush to get it to the lab. But you know, there's a rush because you want a rapid diagnosis. We talked about watchful waiting, particularly in the nursing home setting, and how smelly urine is not actually a criteria for culturing, but I still fight that every day. Well, their urine stinks. Well, it is urine. You know, it shouldn't really smell good. So we talked about a lot of that with the nursing homes. And then we talked about how to get a good sample and why it's crucial. We talked about pediatrics, not to leave out that population. Here at a small community hospital, you know, our pediatricians really want to be sure they're getting a good diagnosis. So we wanted to make sure we were in line with bigger centers. So I talked to the stewards, it's kind of our referral centers, to see what they do with their little kids. Then we talked to the nursing homes. We did mandatory education with the nursing homes. And unfortunately, this was all right before COVID, and we had so much turnover. And, I think we probably need to go back and do it again. But it was really great because it helped empower them to feel okay, watchfully waiting, or not just knee jerk to get a UA whenever somebody was acting the slightest bit different. Next project was seeing if our changes in reflex criteria actually made a difference. And probably we did this too soon to see a big difference, but this was another one of our residents, and she looked at seeing if there was a change from 2020 to 2021 in how we were doing with our prescribing practices. Another huge chart review. She looked at 227 patients from 2020 and 200 patients from 2021, trying to see. We looked at outpatients, the urgent care, the ER, and inpatients to see how we were doing. This is what we collected in terms of our data. And I will say there was probably 10 of us different pharmacists who had to help with the data pulling and putting it into the spreadsheet so that she could get it done, so that she could analyze it and present it. This was a beast of a project. So we looked at all these different symptoms, different things, trying to make sure we had a good round diagnosis pool. So, we looked at, did they have UA positive and physical symptoms, UA positive with mental confusion and falls, UA positive with no symptoms, and on and on. We looked for that in 2020 and 2021. And so what we found is that I pretty much am tight on stewardship on the inpatient side. Outpatient is the Wild West. I knew that going into this project. I knew we weren't doing enough on the outpatient side, but when you're one antimicrobial stewardship pharmacist and one infectious disease provider, it's really hard to reach everybody you need to reach. But we found some other things, like people were getting macrobid for UTIs for months on the outpatient side. We were seeing the urgent cares and the ERs were testing for cure routinely. We were seeing recurrent UTIs over and over again in patients who were not being referred to other specialties for evaluation. So that's really helped us get on our providers and say, hey, if you're seeing the same patient or they're not getting better, we need to have them see GYN, we need to have them see urology, etc. So we looked again at cost. We looked at how much urine we're running. We particularly called out in this project that we were still treating patients for asymptomatic bacteriuria, particularly in our behavioral health unit, which kind of led again to some more projects down the line. But this was a huge project along with our pathway, and I would actually like to redo it now and see how we're doing. But this project gave me a springboard to say, all right, I don't like outpatient stewardship. It's hard for me to get a grip on. I don't know the providers as well, but we're going to have to do something. So last year, we looked at creating an expected practice document, because I know sometimes I can't stop antibiotics from being prescribed. I'm doing my best with diagnostics that I can, besides sitting in the clinic and just talking to people all the time, which is an option, but you have other stuff inpatient. So how can I make antibiotic prescription better in the clinic? Well, I can empower people to use shorter duration to prevent resistance and help better treat UTIs. So expected practice is kind of a compilation of multiple trials that have demonstrated shorter courses of antibiotics are equally as effective when compared to longer. So in addition to clinical judgment, it's important to assess treatment duration for the disease in the patient, but it helped empower physicians, I think, to prescribe less antibiotics. So we looked at all the common infections. We pulled them in the outpatient setting, at least 30 per infection, or whatever we could get in the 6-month time frame we looked at. And so this is just an example of UTIs. So the evidence-based duration of treatment for acute cystitis, 1 to 5 days, depending on the paper you read. Complicated would be 5 to 7. We don't want to treat asymptomatic bacteriuria. So we saw 20 patients with UTIs, 4 that were complicated, 16 that were uncomplicated. 11 patients were treated in accordance to guideline recommendations for an average of 7 days. But we did find that a lot of patients were treated with 10 days or more of therapy, adding up to an extra 55 days total of therapy. So an average of 3 extra days per patient. So we did this for kind of each of the outpatient common infections. And then out of that, Hayden created this expected practice document, which we presented to the outpatient providers and the family practice doctors. And, we'll kind of zero in on uncomplicated UTIs. Your duration relates to your agent. Here's where you might choose one over another. Remember, the diagnosis is clinical, supported by lab findings. Something that can empower the providers to say, okay, 3 days should be enough here if I use Bactrim. 5 days should be enough here if I use cefuroxime. And then what I really emphasized is here's the references on this thing. It's no longer one paper for uncomplicated UTI saying you can do shorter duration. It's multiple papers. So I want people to feel comfortable that we're not just pulling some random journal. And so we actually put this on our antibiogram this year. We have an informational side to our yearly antibiogram. And I put it on there because people from other institutions around Helena, Peerview, we have a lot of new urgent cares. They can get on our internet site and access our antibiogram. And I have it out there so that people can see it. And so people can know, see our sensitivities, because here in Helena, we run most of everything through our one lab. So it has a pretty good community view of our sensitivities. The other project we did this last year was specifically looking at urinary tract infection treatment in our behavioral health unit. So if you have a unit that's problematic, or perhaps you think the diagnosis is not as sterling as it should be, you can focus in on that. And so that's what we did last year. We kind of looked at 6-month period of patients who were treated for UTIs in the BHU, 10 adults and 10 geriatric patients. There were 19 females and 1 male, and you can see they mostly had psychiatric symptoms on admission. The UA is largely gotten as part of the medical clearance to get a patient into the behavioral health unit. And so when we looked at their treatment, what we found is that 0 of 20 patients were febrile, had elevated white count, or any other elevated inflammatory marker. 10 of 20 patients had appropriate documentation regarding any UTI diagnosis and treatment. 12 of 20 were actually inappropriately treated. So 1 of 12 didn't get their full treatment. 2 of 12 didn't get a full course, but 9 of 12 actually didn't meet criteria for treatment. And so here's where we saw any symptoms at all. Most of it was psychiatric in nature. Pyuria not being a symptom, right? Yeah. So I just got approval. I've been working on this one for about 6 months by the head of our behavioral health unit to for patients who are not geriatric. I don't have to have a UA as part of medical clearance. If they don't have symptoms and they don't have any infectious symptoms or systemic symptoms of illness, we don't have to get a UA anymore. For the Jerry's, they did insist on a UA, so I made another one of my pharmacy residents, for her SIDP project, put together a geriatric UTI algorithm specifically for behavioral health, and then one for adults. And then we found out that the nurses were evaluating the characteristics of the urine every day, being smell and color, and then asking for UAs based on that. So we thought, what would be better is if you're evaluating for symptoms, not smell and color. So we actually were able to change some of the things that they're looking at every day, which was great, and kind of modify their charting so that at least if they're asking for a UA, maybe they're asking for something that makes a little bit more sense in terms of diagnosing an infection. And then, another thing I just was working on recently, we were updating our order sets as we prepared to go to Epic. And, I found a pre-checked UA in so many sets. Vomiting and diarrhea, pre-checked UA. I mean, how often do you actually have a positive urine culture if you have diarrhea? It's almost impossible to keep clean. And that's not really a reason for, checking a UA. And I wasn't always successful, but it's kind of another little project. Look at your ER order sets. We know we have to cast a wide net, that's fine, but just making sure that it makes sense that you have your diagnostics in these places can just be another little thing, if you don't have the bandwidth for a big project. And so not all due to urine stewardship, and not to toot my own horn, but when I took over this or started this program in 2016, our antibiotic days of therapy per 1,000 patient days were at 821, which within the last quoted national average that I can find saying 755. And so slowly with each subsequent intervention, as our providers have gotten more and more comfortable, even through COVID, we continue to whittle that down to the 450s, which I'm not saying it's all due to urine stewardship, but I think a lot of it is just ongoing, just getting people used to change, getting people used to the discussion. And, some of it could be urine stewardship. So, sometimes I have to remind myself that this is a ultra marathon type of job. Things aren't going to improve right away. And sometimes you don't even see the impacts of your project for years, or projects, as it were. But it's important to hang in there, because then when you look at this and you present it every year as you present the antibiogram, say we really are making a difference for our community for now and the future. So conclusion, urine stewardship's a huge project. So I think you need to kind of make your problem list. What are the problems? Find a meaningful and doable chunk or problem and just chip away at it a little at a time. And it's easy to get frustrated. I think kind of one thing that I like to do is, okay, what are our strengths and weaknesses with this diagnosis? Kind of like a pro-con list. Okay, strengths, well, we seem to be great at prescribing antibiotics. Good. Weaknesses, maybe our criteria for our lab aren't great. Maybe we have UAs in too many sets. Maybe we're overusing a particular class of antibiotic for UTIs. I will say that data can be hard to get and harder to get through. So props to all my previous residents. I couldn't do it without them. I'm just so proud of them. And many of them take on those projects electively. And I'll say, like, this is going to be a terrible urine project. You really should stay away from this bad boy. No, I want to do it, Heidi. I want us to get better at urine. Okay, great. Our lab is just a standout group of people. I'd say, if you're trying to figure out where you can get better, oftentimes they have an idea, because they have to look at all of that urine and they're going to say, oh my gosh, we just have all these polymicrobial samples and we can't figure out where they come from or what source. People aren't using the collection kit. That's where you find out those little things. Our lab, we just have this excellent laboratory department. I could not do a lot of my stewardship stuff without them. Standard criteria for UA reflex doesn't exist, but a lot of the literature I was looking at says maybe you should hard stop it and people have to put in symptoms before you can order a UA for an infectious workup. That would be awesome. I don't know if that's possible. Wow, that would be great. The provider support here has been incredible. Our hospitalists that I work with day in and day out, we just have a great working relationship. And I can say that from having 6 years of having to work with them, right? It's really hard to do this maybe when you don't know your providers as well, or you're new with the job. And, you don't want to be telling people their business, but I think it's just over time, you become comfortable working with each other and you become comfortable talking about things. And it's unfortunate it's not instantaneous, but it just isn't. And I have to say, providers, yes, but our pharmacists here are just an engaged, super fabulous group of providers who have taken on what I've taken on. And I said, we need a cultureless urine. And those guys are just as hard on being like, well, this patient has no symptoms. They're just really great. Improvements in the ongoing process. So every day we have setbacks. We just try to make the better days more than the setback days. So I think just an ultra marathon of a process. I included here at the end some things about optimizing your analysis, just as idea generators for people. If you're looking for lab things that you can change, because maybe that's not intuitive necessarily to a pharmacist or a nurse or, someone who's in infection prevention, but these are ways you can improve your stewardship that can be very impactful. And then a couple diagrams that are from some papers that I've cited here. New stuff about urine stewardship out there from the Cleveland Clinic, just as idea generating, for ordering, documenting that they get the right sample, only testing patients with signs and symptoms, including nudges to providers as part of their reporting, not to treat asymptomatic bacteriuria, how the symptoms differ based on what kind of catheter or sample patient you're seeing, a lot of those things. I'm looking at inappropriate signs. And then this one too, just out of the 5 Ds of stewardship for UTI, more of an outpatient thing, but also gives you some ideas, but also gives you some successful intervention strategies things you can talk about. We all know that education alone isn't going to be big enough to fix this particular problem, but it's part of it. But there kind of has to be another intervention too. So with that, I actually got through a million of my slides in 45 minutes. So I would be happy to take questions.
Fantastic presentation, Heidi. Thank you very much. So any questions, you guys can unmute and ask, or I guess maybe Jennifer, if you wouldn't mind keep an eye on the chat if anybody submits one via the chat box there. So Heidi, I had a question, and you probably said this, and maybe I missed it, but so you have one lab in Helena that basically does all the analysis and so on and so forth. So are you able to get and do a comparison of inpatient versus outpatient in terms of antimicrobial resistance and so on and so forth? That's since you have one, you have to dance around to different labs and so on and so forth.
I'm not sure exactly how that would go. I wish we could get an outpatient antibiogram and an inpatient one. That would be so nice. I'd have to ask the lab if they track that. I know they do on some level with their outpatient urine because they have it usually flagged out. Kind of in one of those projects, it would be nice to have custom antibiograms, but I haven't done it, but I bet they could. With the advent of kind of Benefice moving to town, now it's kind of changing a little bit because they send all their samples north. And I don't know exactly how much that is, but by and large in the Helena area, St. Peter's runs all of the cultures, or has. That may be changing kind of as we get this different pattern of different institutions coming into different towns. But a great question, and maybe something I can put on a resident for the next year.
Okay, good, thank you.
Heidi, we've got a couple questions in the chat. The first, how do you handle a UA retest to check if an infection has resolved?
Well, I think the first thing that I say there is I have a couple kind of canned examples where I'll have a patient who came in symptomatic for a UTI, received their Bactrim for 5 days, and symptoms resolved, and came back in for a test of cure and grew coag-negative staph. We treated it again. So I have these examples that I like to provide to the urgent care kind of providers, or when this comes up. But I also have guidelines there very clearly saying that that's not the right thing to do and can lead to inappropriate prescribing of antibiotics. So I think it's a conversation to be had. I've asked the lab if there's a way that I can stop that practice. Somebody couldn't get 2 urine cultures in this length of time, and we just don't have robust enough diagnostics to do that. It's kind of similar with C. diff. We see that every now and again where people will want to test over and over again. And I want to say, no, you can't have more than this many samples in this time frame. But then you think to the patient, well, there is a scenario where that could be a sick patient who might need multiples, and you just can't use an all or nothing phenomenon. So I guess what I would say is to have a discussion. Sometimes when it's in the heat of the patient, like they're trying to manage this patient right now and they're feeling kind of contentious about it, maybe that's not the right time to take somebody on and have a good conversation. But the next time would be to kind of come to them later with the data and the literature and some examples and show them that that's really not the case of what we should be doing anymore. Does that answer the question? Hopefully. Dr. Koo, you might have something to say about that too, how you handle it.
Well, actually, I have a little bit of a different challenge on my end. And you, Heidi, I liked what you kind of talked about specifically about building that relationship, because that's very important in antibiotic stewardship, although diagnostic stewardship, not as much, because you're modifying systems, right? So, but, and the reason I kind of point that out is because I have such a high turnover rate in our clinicians. It's hard to build relationship because as soon as you build them, they're gone. and actually that's been kind of what one of our big, I'm just going to say it, is one of our biggest challenges, the high turnover rate and the use of travelers, locums, and such. But I think that the fact that you're able to kind of, you have protected time, I'm assuming, to speak with a clinician, that is probably by far the most effective way. Now, I don't know, and again, I'm kind of it sounds easier than it is to put it into practice. And I'm sure for most of you out in like critical access hospitals, if you're covering multiple places or whatever, it's going to be hard. I mean, and if their providers are not there all the time, then you're hunting them down. So, it's a combination of you have to be in a system where you can both all connect and sit down and talk. And that's and it's easy from those guidelines that you kind of printed out. They're all kind of in that, yeah, that's a great scenario, especially the one that for about bacteriuria. And I'm going to tell you, the one I'm writing for Shay is the same. It's great, we can do it, but to put it into practice is the hardest part. So, and I would say that, if you have to play around with it to see what works. So that coming down to this, but if you can build a relationship, if you can find any opportunity to start building relationship with your clinicians or anyone who prescribes antibiotics, is really, really helpful. But anyway, that's kind of my take. I do have a couple other questions, but I want to make sure that everyone asks their questions first.
I have one more in chat.
Okay.
When you are investigating and find a lack of nursing and provider documentation for symptoms, how do you handle this? Go right to the nurse or provider?
Both, usually. I mean, I kind of start with the provider and I mention, oh, hey, I saw Ms. Smith. She was admitted last night with, let's see, CHF exacerbation. I see her urine was checked and it reflects to culture, but I didn't see any symptoms in there. Specifically, I checked the physical examination. I checked their presenting complaints, both in the emergency department note and then in the admission note. And then they'll say, oh, did they not have symptoms? When I see her today, and again, this is part of that relationship building that Dr. Koo has kind of pointed out is so critical in antibiotic stewardship. I'll just kind of float it out there that I didn't see any symptoms. And my providers now are very good about saying, oh my gosh, they didn't have symptoms. I'm going to ask her today when I see her. Okay, great. Or sometimes they'll say, hey, can you call the nurse? Absolutely. And I'll call up there and I'll just see, hey, how's she doing? Is she voiding without pain? Or I'll go see the patient myself in the hospital. I like to take trips to the bedside. Sometimes in antibiotic stewardship, you get a little too stuck in your office looking at the computer. So sometimes I handle it myself. I go talk to the patient. And, the providers, again, I've developed that relationship that they know I might go in there. I might look at the legs to see what the cellulitis looks like. I might go by and see the patient in the ICU to see what it looks like and how we're doing. But yeah, so, sometimes that nurse who's on the next day may not have seen the acute symptoms. Maybe with some hydration, the patient's already feeling better. So a lot of times I'm looking back at the documentation too, and then just cueing the provider to please ask about symptoms when they go see the patient.
Dr. Koo, questions for you. Oh, hang on. I've got another one. Critical access hospital, first steps to getting a program off the ground. Start with an antibiotic review to highlight initial deficiencies.
I think probably the first thing I would do is look at the regulatory requirements like we did. We did a gap analysis to see what aspects we had that we needed from a regulatory standpoint to, at a minimum, not get cited, for not having a stewardship program, depending on who your regulatory body is. And that can actually help highlight some easy projects that can kind of help get your stewardship started, get administrative support. That can be often a big piece of it, saying we are going to have this, and we had our CEO here sign a letter and distribute to the providers saying this is going to be one of our things going forward. We're going to make stewardship a commitment that we have here to our community and our hospital. And then, sometimes that provides a springboard for getting somebody hired half-time to then do some of these things, because it's hard to do when you have a million other things to do. So I think it just kind of has to be that initial regulatory gap analysis and understanding the implications of getting cited by one of these CMS, Joint Commission, DNV, and then that can be a springboard to say, well, maybe we need to get some support in terms of having a dedicated person, because the guidelines also, the regulatory bodies also suggest that that might be helpful. So I think that's kind of the first step. Excuse me, my nose again. Okay, I'm back.
Well, if you don't mind, I got two quick questions regarding some of the criteria you're using for reflex testing. The first question I had was, was really, did you decided to regarding the reflex testing using 5 white blood cells versus 10, greater than 5 versus greater than 10? Is that, did you pilot that first, kind of just look at cases where greater than 10, using 10 greater than 10 seems to be more likely after a chart review, or did you just arbitrarily choose 10? That's my question, really.
Yeah, that's a hard one. I actually searched the literature high and low to see if there's anything out there that would indicate that 5 would be less likely more than 10. And it was really difficult to find. I didn't have the bandwidth to look at a pilot study, but what I did find is the American Neurological Association actually has a cutoff of 10 to kind of define what should be looked at for infection. And so I used that based on their guidelines. Only because I had seen like 6 white cells reflex with no nitrates, no nothing, no bacteria. And there's nothing more annoying than one criteria when you have no symptoms. So I actually had used the American Neurological Association guidelines. If you have something else, that would be great. I can't exactly remember all the literature I went through, but it's hard to find out there.
There aren't really. I've seen maybe a handful of studies ranging from 5 to 50. And here's the problem: it's that the specificity of the UTI, diagnosing UTI, obviously goes up as you get with the greater white blood cell count, right? So, but the sensitivity goes down, and that's where the biggest debate is. And that's where it's hard to sell to clinicians, because they're always going to argue like, oh, I saw someone with 8 and they had a UTI. So you put a cutoff at 10, then they're going to get all bent out of shape about why did you not get cultured? And this is actually one of the big pitfall about diagnostic stewardship in UAs, you're doing that particular thing, is because of that. And that's a huge debate that even discussed at recent ID week. But I was just curious. I'm saying right or wrong. It's just more just curious of that. My other question really is, when you had suggested 4 different criteria, your new modified version of your conditional reflex urine culture, and you included both the leukocyte esterase and white blood cells. So my own question is, because those two are very directly related, wouldn't you, wouldn't that automatically reflex, because those patients with sterile pyuria will always have those two, and that will always reflex to a urine culture? So that was really my question. Why did you decide to do that?
It was tough. I think going back, you look at what you've done and you're like, oh, maybe I should have left bacteria in there and took out something else. You make a good point, because there's still patients that shouldn't reflex that do, based on those criteria. I'm trying to think why we took bacteria out, because that seemed to, sometimes I would often get the situation where I had nitrates and bacteria. And that to me spoke more highly of asymptomatic bacteriuria than when I had the leukoesterase kind of situation. So, yep, made a decision there, and I'm not sure if it's always the right call. You
can do either or.
Yeah.
Have one of that, and then either of those, and then another one of another criteria. I mean, I would just kind of throw it, because it's like, well, what do you do? Because there's never going to be anyone who has a white blood cells without a leukocyte esterase, or vice versa, right? So if you put those two, you're always going to get a positive, you're always going to get reflex. So, and that was
for my next iteration of urine stewardship, Dr. Fu, I'm going to have to, and I think you live and learn a little bit as a pharmacist. I don't think I had a really great feel for it. And our provider kind of was so busy. She's like, I don't care, just make it cleaner. And you're like, ugh. Okay, I'll do my best. And, you know, I think we can potentially revisit that now that I have a little bit firmer background. But I will say one of the great things that comes out of that is, like you said, you know, the providers sometimes get upset when things don't reflex. We see it particularly for pyelo. You know, the patients come in with kidney pain and you know, the classic symptoms, and their UAs don't reflex. And I get providers that are so upset. And they're like, this urine is completely clean, but I have a symptomatic patient. What am I supposed to do with that? I'm like, send a urine culture. And they're like, oh, yeah, I guess I do have to look at it myself and send a urine culture. I don't know. I wish I had the right answers. If you have them.
There isn't, and that's the whole point. And I just kind of curious because it's not so much you pick, you know, it's just mostly picking on brains that like, oh, maybe there's something I didn't think about because obviously, as you already pointed out, there is no clear criteria for reflex urine cultures, and it's a huge debate back and forth. It's just an idea that sounds great in theory because you're limiting, but on the other hand, it's like trying to. How do you choose and and there are no, you know, there's just a lot of good studies to look at that. Yep. And I'm going to respond. I think, Colleen, you asked me about what we're using. We actually arbitrarily, when I first came here, is just using anything above what's considered upper limit of normal in our that determined by our lab our director of laboratory studies that, you know, if it's above what's considered normal, then it will trigger the reflex. Now, with that being said, having done a lot more reading on this stuff, I'm looking to change that completely because there's a lot more, you know, certainly that what we have right now is going to probably still not going to address directly some of the issues that are being presented here. So, you know, and then it's hard. One criteria, well, any one of the abnormal criteria that's, I think it's as long as it has the right criteria without any evidence of contamination. So I think that's how we had done it. But you're right. There's no, the challenge is you're trying to find that right combination of criteria that will identify the majority of the cases, and that all the clinicians feel comfortable that would serve it will reflex to the cases they will identify as important would be positive. And that's the challenge. I mean, because again, you can always find cases, and they always will bring in those examples that they have encountered, and to justify why your idea of implementing a diagnostic stewardship like a reflex culture is a bad idea. Just gonna say, I encounter that all the time. So, and that's the challenge about diagnostic stewardship, or even antibiotic stewardship for that matter, right? You always have people going, if you make it a hard set duration of antibiotic therapy, they're always going to somebody tell them, but I did this and he failed it and had to come back for another reason, you know, and so this is where the relationship comes into play. You can't do it hard, so you have to have that relationship and then implement these diagnostic stewardship intervention based with that foundation of trust.
And I will say we have those hard stops here at St. Pete's. I get a report every day of people who are at the end or right before the day before their stop. I have to check with providers every day. Hey, Mr. Smith is on day 6 of 7. I'm just making sure you still think that's adequate. And we have the dialogue, you know, but it's like every intervention you make, you realize more and more how much it's backed up by just having a good conversation. And sometimes in other places that's not possible. So it's it's a tough situation. I mean, I wish there was people, a steward and an ID doc at every place. Wouldn't that be nice? So interesting that there's still not really consensus on the UA. I wish that paper would get published.
Well, I want to be respectful of everyone's time. Heidi, that was a fantastic presentation. Thank you very much for that. And thanks for all the interest out there, you guys. I'm sure she touched on a lot of issues that we all deal with all the time. So fantastic. Thank you very much. And I think the slides are going to be available to everyone.
Yep.
Okay. So those slides are there. So hopefully you don't have any proprietary issues there on that, Heidi.
No, and if anybody wants to talk more offline, my email should be, it's hsimons@sphealth.org. I'm happy to share what we've done. If there's anything people can do and use, I'm happy to share it.
Very good. Thank you all.
Thank you.
See you next time.
Yeah,
Thank you, Heidi.
thank you.